Association, and welcome to the fourth part of our Consumer Medical Symposium. As you've heard, if you participated in previous events, this event started 5 years ago and has always been held in the month of March to recognize Bleeding Disorder Awareness Month. There are three key pillars to this event: understanding the current and potential bleeding disorder treatments, the psychosocial impact of change, and the barriers to insurance. So if you were with us on Saturday, you heard the change aspect, you heard the insurance barrier aspect, and the past two webinars, you heard about current and potential treatments. Tonight's forum is based on feedback and is all about COVID and bleeding disorders. When we first planned this, the vaccine was not as widely available as it is now, and we're so lucky and thankful that Dr. Leonard Valentino, CEO of the National Hemophilia Foundation, is with us here tonight to give a great presentation about this really important topic that is affecting all of us. So with that said, I just want to again thank our committee. If you're on the committee, please give me a wave as I say your name. Mark Borlitz, Jenna Brewer, Diane Bruno, Heather Hoysett, Margaret Hudlin, Rachel Katzman, Pat Mancini, Carolyn Miazga, Mike Rudishan, and Mark Zaturka. Thank you all for your commitment in helping us put this event together. I also want to thank our medical providers over the last 3 weeks who have spent time giving these presentations. Dr. Stacy Croto at the Boston Children's Hospital, Dr. Jeremy Madrid at the Dartmouth Hitchcock Medical Center, Dr. Sally Pells at Rhode Island Hospital, Sheila O'Donnell, Maine Med, and Emily Bisson at the Connecticut Children's Medical. Thank you to those that have watched those webinars. The recordings are on our website and will be posted in the chat. I also want to thank our sponsors. Thank you to these incredible companies who continue to support NEHA's mission of advocacy, education, and support. Our presenting sponsors: Bayer, CSL Behring, Genentech, Novo Nordisk, Octapharma, Sigalong Therapeutics, Spark Therapeutics, Takeda, and Unicure. Thank you for your support. And of course, our champion sponsors: BioMarin, Sanofi Genzyme, and Pfizer. And our advocate sponsors: Accredo, Biomatrix, CVS Health, Drugco, HFA, Paragon Healthcare, and Superior Biologics. Thank you for all the support that you continue to give our community. And of course, if you didn't get it yet, this is one of our favorite photos, the Consumer Med Box. For those that received their boxes in the mail, there's a $25 Dunkin' Donuts gift card, and of course, this awesome fanny pack, thanks to Sarah Shinkman, that you're gonna put all your tools in and be as excited as Colin here with this fanny pack. It's almost the half the size of him. But if you didn't get your box, it's coming. We are doing another shipment of boxes. So if you registered for the event last week, then the box is coming, Sarah, next week, right? This week or next week? It's coming soon by the end of the month. So with that said, before I turn it over to Dr. Valentino, I'm gonna stop sharing my screen and we're gonna do a couple of live polls. So if you have your phone nearby, please take it out and we're gonna ask a couple of questions. So the first question, we're just curious. It has nothing to do about COVID, but it is about COVID if you get it, because you wouldn't be able to taste your dinner. What did you eat for dinner tonight? And you can text to 781-412-4971. Again, that's 781-412-7971. So the question is, what did you eat for dinner tonight? Pizza, nice. I have not eaten dinner, so this is all gonna make me hungry here. Ramen, haven't had ramen in a while. I think I need to get that out. Tofu, nice. Dinner, still haven't had lunch. Put your camera on off and go get a snack, whoever said that. Penny with fennel and sausage sauce. I like that. Pizza, sesame chicken and broccoli. I like this all. Yep, definitely making me hungry. The next question is, just out of curiosity, what's the last thing that you ordered online? I hope you didn't order hot dogs and tots online. I think this is from the last one. But we'll just go with it because it's still the food category. So we have groceries. I do love some of this stuff here. Still cooking, nice. Clothes. So this is just a question. We can't track it, so don't worry. We won't call you out if you put anything. A fanny pack, nice. I like the comedy of those. Diapers, a beach umbrella. I like the thinking ahead here. A bathing suit, a bird feeder, a NEHA travel mug. Thank you, whoever put that. We do have a store available that you could buy your stuff. So thank you to whoever bought the travel mug. I think I know who you are, Mark. Shoes, a new car, nice. Online? You want a new car online? I guess you could do that. A Wicked Mom sweatshirt. Yes, we'll get to that in a little bit as well. So last question before we get into COVID, what's the significance of March 24th, which is today? Is it National Cheesesteak Day? Is it National Chocolate Covered Raisin Day? Is it National Equal Pay Day? Or is it all of the above? And if you're on the phone, text 1 for National Cheesecake, 2 for National Chocolate Covered Raisin Day, and 3 for National Equal Pay Day, and 4 of all of the above. So for those on the phone, National Equal Pay Day definitely has a commanding lead. It looks like cheesesteak has no love. The reality is all of the above. Who knew? It's National Cheesesteak Day, it's National Chocolate Covered Raisin Day, and it's National Equal Pay Day. They all have something in common, and we'll get into that into the after party there. All right, the next question. What is your biggest concern about COVID-19 and bleeding disorders? This is an open-ended question. What is your biggest concern about COVID-19 and bleeding disorders? Can I clot? The clotting aspect. That 3 right off the bat. Clotting. 4. So if something comes larger, it means that multiple people are saying it. Platelet drop, clotting. The unknowns. Let's see if anyone else here. And I see the community again. The unknowns. Yeah, so clotting definitely being treated with blood thinners. How long can the vaccine last for? Great. And some of these, so all the questions that you submitted ahead of time have been sent to Dr. Len Valentino as well. So if you have questions, we could put those in the chat. We're just curious. Did you already get the COVID-19 vaccine? So this is not, did you already get the COVID-19? It's the COVID-19 vaccine. Yes, text yes for 1, text 2 for no, text 3, I'm not sure if I'll take it when I'm eligible. And again, we can't track this. We're not going to call anyone out here. So for those on the phone, it looks like 67% said, about 60% have said yes, about 25% have said no, and about 20% says, I'm not sure I'll take it if I'm eligible. So we'll just give it another couple of seconds here, but it stayed about similar. 52% said yes, 26% said no, and 22% said, I'm not sure if I'm going to take it. The last question here, what are you hoping to take away from this presentation? Just anything that you're hoping to take away from this presentation. Calmness, clarity. Let's see here. This could be anything, any more understanding, more info, clarity, understanding definitely came up. So with that said, I think that's a perfect segue. I'm going to stop sharing my screen, and I'm going to now turn it over to our featured presenter, Dr. Len Valentino, CEO of the National Hemophilia Foundation. Dr. Valentino, I now invite you to share your screen, and I'll have you take over for the presentation this evening.
Thanks, Rich. I appreciate the opportunity to present to the NEHA community today. So you should be seeing my screen now. Is that correct?
Correct.
Okay. So yeah, it's a pleasure to be here, and I'm really honored to have been invited to talk to you. So we're going to talk today about these things. So I'm going to start with a little bit of information about World Hemophilia Day and what the role of WFH is going to be, the vision and mission, how COVID will impact the community in the future, talk a lot about the vaccines, a little bit about von Willebrand disease guidelines and advocacy, a BDC teaser, and then a little bit of information about our national research program. So the World Hemophilia Day is celebrated on April 17th, and the theme this year is adapting to change. And I think everybody recognizes the importance of being able to adapt to change given the past year that we've had. And sustaining care in the new world is really critically important. And that's what opportunities like tonight are giving us, is sustaining care as we move forward. So it's held every year on April 17th in honor of the WFH founder. It was first held, as you can see there, about 30 years ago. And it's all about lighting it up red to bring attention to the bleeding disorders community. So, this is how we advocate for bleeding disorders around the world. And I know that the NEHA community is a strong supporter of WFH and the World Hemophilia Day. So as I said, it's about adapting to change. There's the hashtag WHD 2021. So encourage you to be supportive on social media. And this is just a quick message from Cesar Guerrero, who's the president of WFH, emphasizing the importance of the challenges that we've had because of the pandemic for people with bleeding disorders. And we can't stop striving for treatment for all. And World Hemophilia Day is an opportunity for us to show the world that our community is resilient and can overcome this challenge as we've overcome previous challenges in the past. So celebrate with the global community, share your personal story and video at worldhemophiliaday.org. You can post photos on social media, suggest or support the work of WFH and connect to the global community. This is so important. So I wanted to just give you a little bit of idea about the vision and mission of NHF now. So a mission statement is today, here and now, while a vision is tomorrow in the future. And these two are very different, where a vision can be aspirational. So this is the mission of the National Hemophilia Foundation. And you'll see that there are some substantial changes from the previous mission statement. The National Hemophilia Foundation is dedicated to finding cures for inheritable blood disorders and to addressing and preventing the complications of these disorders through research, education, and advocacy, enabling people and families to thrive. The bottom line, NHF exists to encourage and help people with bleeding disorders to thrive. And that's really what it's all about. And we're going to do that through research, education, and advocacy. And really, you'll see in the next slide that our goal here and our vision is now for cures, but not for just bleeding disorders, for all inheritable blood disorders. So the vision statement now reads, a world without inheritable blood disorders. And we need to be good global citizens working with other organizations to enhance the care of people with blood disorders. So I'm going to turn to the next topic. How will COVID impact the community? So we know that this is very prevalent. This is some data that looked at Canadian blood donors. And there were 150,000 donations from 140 unique individual donors. And you can see there that about 50% were screened for IgG antibodies. These are antibodies that result from infection. And after excluding people that were repeat donors, there were about 75,000 people that were included in this study. And overall, during the 10 weeks of the study, the adjusted prevalence was 7 per 1,000 donors. So you can see that it's a pretty substantial number of people are impacted by COVID-19 and have antibodies in their blood. So it's important to then recognize amongst the blood donors that there are some diverse issues amongst these people. And the first is that the rate by donor self-identified rate is quite different. And you can see that in Indigenous people, Asians, and other minorities, the rate is substantially higher than in the Caucasian self-identified white population. And there were slight differences by age, but this was not statistically significant. So really the big difference was by race. And the other was, that was really important to recognize, there was no significant variation in the prevalence of these antibodies by degree of social or material deprivation or by ABO blood group. So really race was one of the strongest predictors of COVID infection. So we need to take that into consideration, especially as we talk about vaccinations. So this is a map that's taken from the Community Counts Registry that looks at the geographic distribution of people in the United States with bleeding disorders. And you can see there the upper Northeast area where obviously many of you are, unless you're on vacation somewhere. There's a heavy prevalence of people with bleeding disorders. So what we're going to be talking about is particularly relevant to the NEHA constituency. So COVID-19, I wanted to talk a little bit about mitigation and prevention. And we've heard this over and over and over. So the first thing is prevention is always best. Masks still are the single best deterrent to infection. Social or physical distancing, I like to refer to. We should stay connected with our communities. So social distancing is not necessary, but physical distancing is. And we're now learning from new evidence that for young people in school, 3 feet physical distancing is adequate, where others, especially adults, we should still maintain a 6 foot physical distance and wear a mask if you can't maintain that distance. Hand washing and using 70% alcohol hand sanitizer is important. And then isolating people with or suspected to have COVID-19 from others to prevent the transmission. And then isolating people with exposure to people with COVID-19 is also important. So, you can see these prevention strategies are important. And then, just a do about wearing a mask. It's important that the mask cover your nose and your mouth. It's amazing how many people you see, whether you're in the supermarket or other public places, that really don't understand how to wear a mask. And that includes many of our elected officials that you see on television who really don't understand the value of proper mask wearing. Physical distancing, as I said, is 6 feet, and it's important to recognize that distance, especially indoors. And then if you aren't able to keep the 6 foot physical distance, it's important to recognize the importance of the mask. So I wanted to turn to this really important publication by Dr. Pipe at the University of Michigan and colleagues from the Safety and Supply and Access Committee of the World Federation of Hemophilia. And this really addresses a number of the questions that you posed before this presentation about the management of COVID-19 in people with bleeding disorders, including hemophilia. So I'm going to start by talking again, turning to health equity. And health equity is achieved when every person has the same opportunity and no one is disadvantaged because of social position or other socially determined circumstances. And again, this is critically important because we're on a journey here, and we're on a journey that is important that we all can achieve the best outcome. So what are our challenges? And obviously coronavirus and COVID-19 is a major challenge, but also diversity, equity, and inclusion is an important challenge. So equality and equity are not the same, but really liberation is eliminating the sources of inequity. But what we're really striving for is inclusion. So bring traditionally excluded individuals and their groups into processes, activities, and decision-making, as well as policy-making, in a way that shares power and encourages equal access to opportunities and resources. And this is something that we're striving for, not only with COVID-19, but in the inherited blood disorders community moving forward. So next, I'll turn to COVID vaccines. So here in this table, you see that there's a number of different vaccine platforms that are being used. And I put the number of candidate drugs that are in development, the number in human trials, the number that are authorized or approved in at least one country, and the number of countries that have authorized that. So you can see that there's a number that are using non-replicating viral vectors. This is something like AAV. And you can see that they're authorized in at least four of these have been authorized, and 55 countries have authorized this type of vaccine. So this is a really important type of vaccine strategy moving forward. But what we all know about are the RNA-based vaccines. There's 36 candidates aside from the 3 that we know about. And actually the table should have been updated. There should be 3 on this slide as opposed to 2 that are authorized. And you can see that those 3 vaccines, the Mrna, Pfizer, and Janssen or J&J, are authorized in over 42 countries. Inactivated virus, that would be something like what's traditionally done with the flu virus. And that's platform strategy. There's 19 different candidates, and there's been several candidates that have been approved, and many in many different countries, 25. So you can see there's a lot of different strategies to develop vaccines for COVID-19. So traditional vaccines leverage the ability to give either part or protein from a virus that then provokes the immune response to make antibodies. And one of the hopes is that not only do you make antibodies, which in this case is a favorable response, you also trigger a cellular immune response. And that cellular immune response is critical for long-lasting immunity. We don't want to just have antibodies present for today, but we want to have cellular immunity for tomorrow and into the future. So that's really what the vaccines are looking to be able to do. So the novel vaccine platforms, as I said, there's a number of different candidates. We know about the mRNA coding vaccines. These are injected and force your body to make a viral protein, usually the S or spike protein, and then your body responds to that by making antibodies. There's also recombinant SARS-CoV-2 or the coronavirus surface proteins that could be used to form antibodies. And then the other is a viral vector packaging a SARS-CoV-2 gene that produces a viral protein, much like the mRNA. So there's a number of different strategies that are used in these vaccine platforms. So the vaccines, as of the end of February, there were 12 vaccines authorized by at least one national regulatory authority for public use. 2 of the RNA, now there's the 2 RNA, the Mrna and the Pfizer, 5 viral vector vaccines, and that would include the J&J, 4 conventional inactivated vaccines, and 1 peptide vaccine as well. So lots of different strategies to do this. In the United States, we have 3 of those available to us. And as of February 24th, 22 million doses of COVID-19 vaccine had been administered worldwide. This number is now approaching 300 million. So this is a list of authorized and approved vaccines. You can see on the top is the Pfizer Bioentech vaccine that was produced in the United States and Germany. And again, this uses a modified RNA that's put into a lipid nanoparticle or LNP to protect it from the body so that it can actually do its job. There were over 43,000 people that were studied in the phase 3 trial, and it's been authorized or fully approved in 34 and 11 countries. So you can see that it's quite extensive use of the Pfizer BioNTech. Next on the list is a Russian virus, the Sputnik 5. This is an adenovirus, serotype 5 and 26. It's important to recognize that this is not AAV. This is an adenovirus, much like the Oxford AstraZeneca vaccine that was developed in the UK. These are adenoviruses. Adenovirus is a common cold virus, not AAV. So if somebody were considering participating in a gene therapy trial for hemophilia A or B, either of these types of vaccines do not preclude you from participating in that gene therapy trial. You will not develop AAV antibodies by receiving an adenovirus-based vaccine. And again, you can see that the Russian vaccine has been given emergency use authorization in 34 countries, but and fully approved in 5, and the AstraZeneca 28 and 3. There's a couple China manufactured viruses vaccines that you can see there, with large numbers of people who participated in those clinical trials. And again, you can see that their use is fairly broad in different countries. The Mrna vaccine was developed in collaboration with the National Institute of Allergy and Infectious Disease in the United States. Much like the Pfizer Bioentech vaccine, this is a modified RNA vaccine encapsulated in a lipid nanoparticle. It's been received emergency use authorization in 9 countries and fully approved in 5 countries. The J&J, again, developed in the United States and the Netherlands, is an adenovirus vaccine, not AAV. 40,000 people participated in these clinical trials, and it's received emergency use authorization in 3 countries, but no country has fully approved this vaccine. So you can see there's other vaccines there that are less used across the globe, several from, a couple more from China, another Russian vaccine, one in India, as well as the last one is another Russian vaccine. So the opportunities to vaccinate the global population will be there. It's a matter of will and the ability to pay. So again, we looked at this a little bit. So the 12 vaccines we talked about, the 66 vaccine candidates are in clinical development. 17 are in phase 1 trials, 23 are in phase 1/2 trials, 6 are in phase 2, and 20 are in phase 3. So the time from phase 3 trial to authorization or approval is typically somewhere around 9 to 12 months. So we see that there could be an additional 20 vaccines that are available in the next several months for use by the global population. So what makes a vaccine effective? So first, of course, it has to be immunogenic. It has to elicit an immune response. And you may have heard recently about several viral vaccines that have actually been stopped from their clinical development programs because they failed to elicit a sufficient immune response. So immunogenicity is the top thing that has to be checked off. The next, of course, is it has to be safe. It shouldn't cause the disease that it's designed to prevent. And the vaccine shouldn't cause immediate life-threatening reactions. The vaccine should stimulate production of neutralizing antibodies, and not all antibodies are created equal. And we know this from the hemophilia population. Antibodies are what we're concerned about when people develop an inhibitor. These are antibodies against the factor VIII or factor IX protein. In terms of the COVID vaccines, we're looking for antibodies that are developed against the coronavirus causing COVID-19. So the important component of this is that neutralizing antibodies are essential. And the adaptive immune response should be protective and not harmful. So this is what develops after receiving a vaccine. And when you're exposed to the same pathogen again, you should have immunity and not a harmful immune response. So what about allergic reactions after mRNA vaccines? So this is a study from close to you, Mass General Hospital and the Brigham and Women's Hospital, where there were almost 65,000 employees who participated. And about 26,000 received the Pfizer Bioentech vaccine, and close to 39,000 received the Mrna vaccine. So what was the outcome for these individuals? Acute allergic reactions were reported by 1,365 employees. Now, it's important to recognize that many of these employees are healthcare workers, and many of these are had been exposed to people with coronavirus. So with the Mrna vaccine, there were 2.2% of the recipients had acute allergic reactions. And about 2% of those who received the Pfizer BioNTech vaccine had an acute allergic reaction. So most of these allergic reactions included wheezing, a skin rash, and other relatively minor symptoms. But severe symptoms of an allergic reaction or anaphylaxis occurred in 16 employees, 7 who received the Pfizer Bioentech, and 9 who received the Mrna vaccines. So it's important to recognize that serious adverse events, such as anaphylaxis, can occur with these 2 vaccines. So anaphylaxis occurred in 2.47 per 10,000 vaccinations. Now, it's important to recognize that 94% of these individuals who had an anaphylactic reaction were females. Now, that could be a sampling issue related to the population that was studied. It's still not clear whether this is an important factor, but women who receive either the Pfizer BioNTech or Mrna vaccines should be particularly aware of the possibility of anaphylaxis. 2/3 of the people had a prior history of allergic reactions, and 1/3 had a prior anaphylactic response. So again, people who have allergy to vaccines or to other drugs should be particularly mindful of this possibility. And of course, if you have a history of anaphylaxis, you should take precautions regarding this risk. The best thing for you to be able to do is to talk to your healthcare professional, your hemophilia treatment center, or other healthcare professional about what your particular risk might be before you receive a vaccine. So what this is a commentary about vaccination, the rationale, modalities, and precautions for patients with hemophilia and other bleeding disorders. And this was just recently published. And I want to go through this in some detail because I think, again, this answers many of the questions that you have. So first, people with bleeding disorders are not at a greater risk of contracting COVID-19 or developing a severe form of the disease. So they are not considered a priority group for vaccination. We get many questions every day from the community about this. Why are we not considered a priority group? This is one time we should be grateful that we're not in a high priority group. So vaccine safety, I think, is another thing that we can talk about. Again, there's a reporting system called the VAERS, and this is the US Vaccine Adverse Event Reporting System. So this system has identified that about 372 out of every million vaccines that are administered cause a non-serious reaction report. Some of these are fatigue, pain, headache, arm tenderness, et cetera. And you can see the list of non-severe side effects. The University of Oxford AstraZeneca inactivated adenovirus-based vaccine had a rate of about 0.4% compared to the mRNA vaccines of 0.37. So a tenfold difference in vaccine serious event rate. And the Sputnik adenovirus vaccine, there's too little information to know much about that one. So I want to point out also that there's a Mesac recommendation on administration of vaccines to individuals with bleeding disorders. So again, consult your healthcare professional, your hemophilia treatment center before receiving a vaccine so they can give you proper instructions regarding administration of the vaccine. So the guidance, again, that was provided from the previous publication talks about, again, people with bleeding disorders are not at greater risk. The vaccine should be administered intramuscularly using the smallest gauge needle available, typically a 25 to 27 gauge needle if possible. However, some vaccines are administered using an accompanying needle and syringe combination. So the use of an alternative may not be possible or even desirable. Pressure should be applied to the site of the injection for at least 10 minutes after you receive the injection to reduce the risk of bleeding and swelling. That's an important precaution that needs to be adhered to. Next, self-inspection and palpation of the injection area several minutes and 2 to 4 hours later is recommended to ensure that there is no delayed hematoma formation. Typically, after you receive a vaccine, they have you stay in a waiting area for about 15 minutes. and you're supposed to self-inspect and palpate the area. That's an important thing for you to be able to do. But then again, you should continue doing that 2 to 4 hours later, and I would recommend for the next day as well. Discomfort in the arm that's felt 1 to 2 days after the injection should not be taken as a serious concern. This should not alarm you unless it worsens and is accompanied by swelling consistent with a hematoma. If that occurs, you should contact your healthcare professional or your HTC. Any adverse events, a hematoma, an allergic reaction, should be reported to your hemophilia treatment center or healthcare professional. Patients should contact their physician immediately or go to the nearest hospital emergency room right away if they experience an allergic reaction. For patients with severe or moderate hemophilia, the injection should be given after a dose of factor VIII or factor IX concentrate. For patients with a baseline factor VIII or factor IX level above 10%, so that would include all the people with mild hemophilia A or B, as well as those who are receiving factor concentrates. So you should, there should be no need for administration of a factor concentrate if your baseline level is above 10%. Patients who are on emicizumab, whether you have an inhibitor or not, can be vaccinated using an intramuscular injection without additional injection of factor VIII and without receiving any additional doses. So it's again important, if you're receiving emicizumab, that should be sufficient to prevent bleeding or a hematoma to form. Patients with type 1 or type 2 von Willebrand disease, depending on your baseline von Willebrand factor level and ristocetin cofactor activity level, should use therapies if available, such as tranexamic acid. We all know that DDAVP is not currently available, but it was included in the recommendation because it was available when this was published in 2020. You should use therapies in conjunction with the Hemophilia Treatment Center, and patients with type 3 von Willebrand disease should be given an injection of von Willebrand factor containing concentrate. Again, consult with your Hemophilia Treatment Center. For patients with rare bleeding disorders, including those with a low platelet count or a platelet function disorder, should be vaccinated. This is not a contraindication to receiving a vaccine. Patients on anticoagulation should have their prothrombin time tested within 3 days of receiving the vaccine. And if the results are stable and within a therapeutic range, they can receive the vaccine intramuscularly. Another important point. And rounding it out, there are no specific contraindications to vaccination related to complications of hemophilia or other bleeding disorders or their therapies. Immune tolerance, treatment of hepatitis C or HIV, and other conditions are not contraindications to the vaccine. And vaccination is not contraindicated for patients on immunosuppression, whether that's cortisone or other immunosuppressive drugs, irrespective of what the reason why they're receiving those immunosuppressive drugs. So we've talked about the COVID-19 vaccines. I wanted to turn for a minute and talk about the von Willebrand disease guidelines. This was an international collaboration between the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the World Federation of Hemophilia, and the National Hemophilia Foundation. So 2 patient organizations, NHF and WFH, collaborated with 2 professional organizations, ASH and ISTH. The real work of the guidelines now starts. And the first thing that has to be done is broad education. Education of the community, education of healthcare workers, education of our payers and our policymakers as well. So NHF is looking into all opportunities to educate the public as well as every important stakeholder. The other important component of the guidelines is we need to look at the value of these guidelines, collecting data. How valuable are they? How are they changing behavior? And how are they improving the quality of life for people with von Willebrand disease? As I said in our mission statement, the goal of the National Hemophilia Foundation is to enable people and families with bleeding disorders to thrive. How do these international von Willebrand disease guidelines help people with von Willebrand disease thrive is a question that we're going to be actively investigating over the next several years. Next, I'd like to just give you a little bit of a teaser on the Bleeding Disorders Conference. So some of the highlights: there'll be a public health session for women, health equity, and aging. There'll be a policy and advocacy session talking about current legislative issues, the blood and product safety considerations, and of course, an insurance session. There'll be a nursing pre-con on von Willebrand disease and a physician track session exclusively dedicated to von Willebrand disease. Again, there'll be a medical education session, a chapter track, and provider tracks for nurses, physical therapists, social workers, as well as physicians. The Bleeding Disorders Conference will be held virtually August 26th to the 28th. I encourage you to participate and join your fellow people with bleeding disorders and network with providers. Lastly, I'd like to just give you a little bit of information about the NHF State of the Science, where we're going to be establishing research priorities and facilitating research capacity. I'm pleased to co-chair this with Dr. Michael Reck from the University of Oregon, and now the Chief Science Officer at the American Thrombosis and Hemostasis Network. We're joined on a steering committee by Dr. Shannon Carpenter, Jill Johnson, Barbara Conkle, Sarah O'Brien, Steve Pipe. Our consultant is Dr. Donna D. McKelly, formerly from the National Heart, Lung, and Blood Institute, and Michelle Whitcop from NHF is coordinating and organizing this. And I would be remiss if not recognizing the significant contributions of our patient representative, Esmeralda Vasquez, who's a young woman who has a rare congenital platelet disorder and is also a healthcare professional. So she brings a number of important qualities, including the patient voice, to the steering committee and the research State of the Science. We have 6 working groups that have been established. The first around hemophilia A and B. The second is von Willebrand disease, platelet disorders, and other mucocutaneous bleeding disorders. The third working group will focus on research priorities for rare and ultra-rare bleeding disorders. The fourth working group is one that I'm particularly impressed in and interested in seeing the outcome from. And these are research priorities for girls and women and people who have the potential to menstruate. This working group will focus on the sex and gender biology issues that women and girls and people who menstruate have across all bleeding disorders. The fifth working group is around implementation science, diversity, equity, and inclusion, and how we can bring research closer to the population. And the sixth working group is all about facilitating research and developing an infrastructure to support research as well as funding. So with that, I've now covered everything that I wanted to talk about, and I think we have plenty of time for questions at this point. So thank you very much for listening to me, and now I can listen to you and try to answer your questions.
Thank you so much, Dr. Valentino, for that excellent presentation. I think many of us would agree. I could probably listen to you talk for several more minutes here. I would say hours, but then we're going to bedtime. So some questions that came up here that I will toss your way is, can you comment on how and why people are responding differently to the vaccines? I had a significantly different response than other family members, and just a preference that this community member does not have a bleeding disorder.
Yeah, so this is a great question, Rich, and I think it's one that's really important. We don't have enough information to understand why some people have a reaction, whether that's fever and chills or a headache or arm pain where they got the vaccination. So it's important to recognize that everybody brings a different history into the vaccination. And importantly, they bring a different genotype. So their personal genetics are different. Even if you have an identical sibling, you're somewhat different based on the experiences, things that you've encountered in terms of infectious diseases in the past. So we have to take everybody as an individual. I think as we get hundreds of thousands of people vaccinated and begin to collect this data, we'll begin to understand, hopefully, why some people have a different immune response. The other point that I'll make is that having a more vigorous immune response does not necessarily mean that you will have a better vaccine response. We don't have that evidence at this point. And I always tell people you don't have to get sick to get better. And this is a great example of that.
Fantastic. Thank you so much for that great answer. For someone with a bleeding disorder, does it matter which vaccine you receive?
No. So there are three currently available vaccines: the Mrna, the Pfizer Bioentech, and the Janssen or J&J vaccines. Any of these three are okay for anybody with a bleeding disorder, whether you're on treatment or not. The difference is, again, the Pfizer Bioentech and the Mrna vaccines are mRNA vaccines that require 2 doses. The Janssen vaccine is a single dose. And again, it's a different strategy that's been used to develop this vaccine. But any of those three are equally effective and available for people with bleeding disorders.
Great, thank you. Of those who experience an allergic reaction to the vaccination, do those individuals have any pre-existing allergies or anaphylactic reactions in the past?
Yeah, so as I showed you, people who have had an allergic reaction should pay particular attention to this risk with a vaccine. So as I pointed out in the Mass General Brigham and Women's Hospital study, that included 65,000 people, anaphylaxis occurred about 2.5 times per 10,000 vaccines that were administered. 2/3 of the people who had the anaphylaxis had a prior allergic history, and 1/3 had a history of anaphylaxis. So if you have a history of allergic reaction to medications, or more importantly, an anaphylactic reaction, you should be particularly attentive to this possibility and consult with your healthcare professional before receiving your vaccine. You're on mute, Rich.
You'd think I would know this by now. How many months have I been going on? And then you just start talking to yourself before that thing pops up. So thank you. Should an individual report side effects through the vaccine adverse event reporting system?
Absolutely. So I received my vaccine 6 weeks ago yesterday. And at first you get a text message daily for the first week. Then after that, you get it twice a week, and then it goes to once a week. So tomorrow I'll expect to get my weekly VAERS reminder to log in any side effects. Absolutely. This is the only way that we can track the adverse events for these vaccines. It's critically important to participate.
Great. All right, another question that came in. My son has an inhibitor, which is an autoimmune response. Will he have a reaction to the vaccine, or if he gets COVID, will it be worse than others since the inhibitor is autoimmune related?
Yeah, so the inhibitor is alloimmune, not autoimmune. So the alloimmune response is against the injected protein, the factor VIII or factor IX that's administered into the body. So there is no data that people with an inhibitor are more or less likely to have an adverse event with receiving the COVID vaccine. What we know to date is that people with an inhibitor should be vaccinated, just as everybody with an inherited bleeding disorder should receive the vaccine. Again, I would consult with your healthcare professional, your hemophilia treatment center, about the particular issues with your child, but I would strongly advocate to receive the vaccine.
Great information, thank you. We've heard in the news a lot about mutations. It seems like every day there's a new mutation of a different strand, and the news likes to report upon this. How do mutations affect potential vaccinations, and how do we monitor that after we get the initial vaccine dose?
So another great question. So think about the flu vaccine, the influenza vaccine. Every year there is a new flu vaccine that is developed by the manufacturers of the influenza vaccines. And this is because there's what's called antigenic drift. Each year, the influenza virus changes slightly. As it replicates, there's a chance for mutation. And the more a virus replicates, the higher the rate of mutation is. So if we could control the COVID-19 in the population, get herd immunity, and decrease the replication of the virus, the likelihood of having these mutations develop will decrease. But it's highly likely that this will continue, that we'll need to get COVID-19 vaccines, much like the flu vaccine, on an annual basis or at some frequent interval, yet to be determined, because it's likely that this coronavirus will continue to mutate as there's prevalent infection in the population. So unless it's completely eradicated, in other words, like polio, for example, polio is eradicated, so there's no mutation rate because the virus is not replicating in the population.
Great, thank you. If my child with severe hemophilia were to hypothetically contract COVID, is there any impact that may have on his prophy regimen?
Yeah, so this is a complicated topic. And we know that people who get COVID-19 are at a higher risk for a number of complications, because we know this virus infects blood vessel cells. And the blood vessel cells are designed to keep the blood flowing throughout the body. When the blood vessel cells can become infected, they can actually change their behavior and participate in blood clotting. So we learned very early on that the administration of blood thinner medications were critically important to the reducing the morbidity and the mortality in COVID-19 infections. If a person with hemophilia were to get COVID-19, they would also have an increased likelihood of developing those blood clots. So it requires a very delicate balance between administration of drugs, your factor, to prevent bleeding, while also giving medications to prevent blood clotting. So this is an area that requires the expertise of an intensive care unit that's associated with a hemophilia treatment center. This is not a simple management task. So this is something where you definitely need to have the expertise of the hemophilia treatment center providing care to a patient with a bleeding disorder and COVID-19.
Thank you, Dr. Valentino. A question that came in the chat, which is a really good one. If I recall correctly, about 17% of people on this call, as well as about 30% of people countrywide, are unsure about getting the vaccine. What might someone sway to get them protected?
Well, I think the first thing is I've been vaccinated. So it's a personal attestation of my belief in the safety as well as the efficacy and importance of receiving the vaccine. So I think it's people like us who are getting vaccinated that are the most important message carrier. I think the other to sway people to get the vaccine is the whole argument about the mutation rates. The more virus that we have in the population, and that is directly related to the number of people who are not immune, i.e. the number of people who don't get the vaccine, there'll be higher mutation rates, and those mutant viruses are either going to be more likely to spread, more contagious, or they could be more deadly. So the risks will be much higher as we have a substantial number of people who do not receive the vaccine. And this is true worldwide. So eradicating this pandemic is a global goal, not just for the US, because if you ever want to travel outside of the United States, or if anybody from outside the United States wants to come in, we need to eradicate this virus from around the world, not just the US. So get your vaccines.
Yeah, and if that didn't sell you, Krispy Kreme gives you a free donut with that card. So
Every day, every day.
yeah, so there's a lot of enticing here to get that vaccine. Another question that came in, and you touched upon this, maybe you could talk a little bit more. Does the COVID vaccine disrupt our platelets?
So there is some evidence, mostly anecdotal, that there is could be an issue with platelets with the COVID-19 vaccine. There have been a small number, around 30 cases reported, but that's among millions of doses of vaccine that have been administered. So although true, the vaccines have been given, and true, there have been low platelet counts reported, it is not clear whether these two are related together. So again, we tell people that they should monitor for hematoma formation afterwards, but it's not a reason not to get the vaccine.
Great. And speaking of that vaccine, I'm going to toss a question out there because I think we're all grappling with this. When in-person events start again, you know, many of us have camps or the BDC or Fall Fest. Do you foresee bleeding disorder organizations mandating vaccines to attend these conferences, or what are your thoughts on that?
Well, I think that it's clear that it is possible for organizations to do that they can mandate it. So, you know, it's unclear whether or how many organizations will do that because of the fear of a risk of alienating people. But I do think that, for example, it's going to be highly likely that you are not going to be allowed to fly on an airplane without having had your vaccine. And, you know, there's already talk about vaccine passports. To get in and out of the country, you're going to need to have this vaccine passport. My guess is that it's highly likely you will need to have your vaccination card to board an airplane or even to get through security. So I don't see a reason why organizations would not do the same thing. Our goal is to protect the community. Our goal is to support and protect our community members. So advocating for and requiring a vaccine, I think is critical. There's many states that require vaccinations for children to go to school. You know, currently those under the age of 16 cannot receive a vaccine because they're not authorized for use in the United States in people under the age of 16 for the Janssen vaccine under 18. So we'll see, you know, the clinical trials have already started with vaccinations in children as young as 6 months of age. And as those trials progress, I think we'll see more data and the possibility of vaccinating children, adolescents, along with very young children.
Excellent answer. Thank you. I apologize if I butcher this, but I'm going to go for it. Head first. If you have severe thrombocytopenia, did I get it right?
Yep, good.
Yeah, not from ITP. What is the risk emergency preparation from vaccine-induced thrombocytopenia?
All right, so that's a really complicated question. Sounds like one that you need to talk to your healthcare professional. So if you have a low platelet count, you would be strongly advised to talk to your healthcare professional before receiving the vaccine, because a low platelet count in and of itself is a risk for hematoma formation. It's not a reason not to get vaccinated, but you should take precautions that your healthcare professional can outline with you. If you develop thrombocytopenia after a vaccination, again, consult your healthcare professional and they'll help you deal with that.
You said it so beautifully. My heart fluttered when you said that word. Say it again.
Thrombocytopenia.
Yeah, I think we need to have a Zoom call to go over big medical terms that we can all get right here. Going back to the conversation about VWD, there's a lot of VWD support groups, and the comment was that that this patient often belongs to them, and CDCs and NHF and many others often still say hemophilia organizations within the group. Do you see the name changes as more attention is brought to the VWD community?
Absolutely. Yeah, I think this is something, you saw that our mission statement and our vision statements have evolved. And the National Hemophilia Foundation, in its original incorporation papers in 1948, were for blood disorders, did not specify hemophilia alone. It actually specified for blood conditions. So going back to the roots, going back to the original intent of the Henrys in terms of the National Hemophilia Foundation is blood disorders. And I think that includes von Willebrand disease and platelet disorders and hereditary hemorrhagic telangiectasia, which is another big word. So you can just abbreviate that HHT, as well as all the rare and ultra rare bleeding disorders. So, none of those are hemophilia, but hemophilia is considered sort of a synonymous with bleeding disorders. It has the greatest recognition, but we need to do more to increase the recognition of von Willebrand disease. When 1 in 1,000 people are affected with this disorder, we should not have to refer to it as a hemophilia. We should call it by what it is, which is von Willebrand disease. So yes, I do see evolution in the names.
Fantastic. Thank you, Dr. Valentino. One other question that I see that's outstanding here is, will it be possible for a level of immunity to be achieved by the community that it will be safe enough for unvaccinated children to travel or participate in community events?
I would hope so. So again, though, it will depend on the level of virus in the community. So children are not immune to getting COVID-19. And we know that there's this multi-inflammatory syndrome that occurs predominantly in children that can be fatal. So the manifestations of COVID-19 in young children can be very different than in adults. My feeling is that if a vaccine is authorized and eventually approved for use in children, that we should have our children vaccinated.
Great. Thank you, Dr. Valentino. I don't see any other questions.
Can I ask a question?
Yeah, please do. Yeah.
So this is somewhat of a rhetorical question, targeting the 20-some% who said they might not receive a vaccine. My question to you is why? One of the answers that people frequently give is, well, I want to see a little bit more information. Okay, that's a valid answer. You're seeing more information. And I think at some point you're going to have to make that decision to receive the vaccine. If you want to return to any semblance of a normal life and participation in activities, you're going to need to consider receiving that vaccine, unless there's a very clear medical indication not to. So, the clear question is, why not? We know that these vaccines are safe. They're highly effective, and we really need to get the community vaccinated to reduce the viral load in our communities so that mutation rates decrease and we can move on, past this pandemic.
I think that's a great example. I'll share personally, my dad was on the fence about taking it, and he called me and he said, my work is offering it. He works for the town that we grew up in, and he's a mechanic. And he said, I don't know if I'm going to take it. There's not enough of data. And once my brothers talked to him, and we said, you have two choices. You do nothing or you take the shot. And really, our chances of living somewhat back to normal is taking the shot now that he has grandkids. And he did take it. But I just think it's interesting that family comes to family and friends, and having these conversations is good. It's good for all of us to love those that are in our lives and explain to them, just as you did there. So thank you for that. There was a comment in, what about the Bill Gates microchip with a wink?
Yeah.
It's coming, Scott. It's coming. Don't you worry. That's what the second vaccine or the booster shot there. So we don't want to give too many things away. But Dr. Valentino, man, you were up to bat tonight, and you hit a home run. We threw those balls fast at you. But thank you so much for your time. Thank you for your expertise, and thank you for spending your evening with the NEHA community.
Yeah, thank you for the invitation. Anytime.
Great. Fantastic. Well, with that said, I'm going to go back to our buddy Colin here. The consumer med boxes are coming out next week for those that registered later. Again, these were metaphorical to put all the tools in them, and we want to see you wearing them at NEHA events. I also want to just give a shout out. The exhibit hall is still open till March 31st. We're going to be sending emails out about that. The link will be posted in the chat. There's a lot going on in the exhibit hall that you can check out companies, watch videos, interact. I know we had some issues with the chat feature on Saturday, but you can schedule appointments if you're interested in any of these companies. Also, the scavenger hunt, it's still going on. Everyone that completes at least 4,000 points, and there's trivia questions for the adults, gets a $50 Amazon and/or Target gift card. Everyone loves gift cards. So you could play in bed, you could play in the morning, you could play in the weekend. It's open until March 31st. And then anyone who completes all the missions in there gets entered into an additional $100 Amazon gift card. You could download a Goose Chase. We've been using it over the past year. It's a great tool, free. The game code 67K6G7 and the password is NEHA. But all this is on our website as well. Just want to give a shout out just in time for Mother's and Father's Day. We have these really neat crew neck shirts available in heather gray, charcoal gray, navy blue, and burgundy. In both colors, they are unisex. Big shout out to Gabby and our development committee for launching these. They're $30 each, and the proceeds go to our emergency assistance fund, which all can be found in our NEHA store as well. Again, I just want to thank our sponsors. Thank you for continuing to believe in NEHA. Without your support, we could not put programs on like this. So we truly appreciate if you are on this call tonight listening. Thank you for what you do. And thank you. You've been with us. You put your seatbelt on last year when Consumer Med was our first program that we had to postpone from March until July, and now we're post a year, and fingers crossed we will have an event this year in person to see you, not through our screens but in person. But with that said, thank you for joining us tonight. We appreciate you be part of this experience. Again, thank you, Dr. Valentino. Sarah, you're a rock star for doing so many things behind the curtain there. Have a great night. If you didn't eat dinner yet, get some food, or maybe go get a Krispy Kreme donut. Whatever floats your boat. Good night, everyone. Thank you.
Thank you.